In this, the third chapter of the text, we'll begin our exploration of quality improvement systems and the domains of quality within such a system. Once completed with this module, you should be able to define the three domains of quality improvement in EMS, identify the three components of EMS quality management, apply a strategy for each domain of quality, apply an appropriate technique to the proper domain of EMS quality given a list of QI processes, differentiate the levels of measurement on outcomes for EMS patients, and identify how an outcome in the system is influenced by structure or process. To begin our discussion about the domains of a quality improvement system, consider this scenario. An engine crew responded to a residence for a patient suffering from a heroin overdose. As part of the crew's protocols, an order was obtained from medical control to administer Narcan. The paramedic established an IV and drew up the medication while a firefighter was bagging the patient and the crew's captain was obtaining a medical history for the patient. Shortly after the medication was administered, the patient's heart rate increased significantly without any noted change in the level of consciousness. It was at this point that the paramedic realized epinephrine had been administered instead of Narcan. From the facts provided, it is pretty clear that a medication error occurred. What do you believe are the underlying causes for this error? What aspects of the structure and process failed? How do you believe your organization would handle an incident like this? With that in mind, what do you think would be best practice for handling such an error? As an introduction to this chapter, the components of any system must be defined before it is possible to understand the details of that system, and a quality improvement system is no different. To begin, the framework of a system details a group of independent but interrelated elements comprising a set of unified whole components of a system. Utilizing the work of Avidis Donabedian, a physician with subject matter expertise in quality, three domains or areas affect quality. First, the structure in which quality improvement will occur must be defined. After that, the next step is to improve process reliability and reduce variations, which should result in quality outcomes. It was argued by Deming that problems within any type of workplace system are predominantly caused by elements that are within the domain of management to control. While the percentage of what can be attributed to management varies based upon the particular resource cited, management is more often than not responsible for problems in the system. As an example, management has the ability to control material specifications, equipment standards, personnel practices, workstation design, service delivery expectations, and so on. All of these various factors contribute to variations in output that impact quality. Strategically, a failure on the part of management to plan for the future and to foresee problems results in costly waste of time, energy, materials, and productivity. When evaluating systems in EMS, traditional quality improvement efforts focus solely on reviewing patient care reports. Such efforts, when used alone, do very little to improve quality within the organization and can have a detrimental effect by assuming any quality issues that arise are at the provider level, which means the only solutions are to provide feedback and education to the providers or to begin the disciplinary process to fix problems. As the saying goes, if the only tool you have is a hammer, every problem looks like a nail. By focusing on just one component of a much larger system, quality improvement efforts are often ineffective and doomed to failure. In comparison, other healthcare disciplines look at quality improvement more holistically across the entire system. The patient record may be a part of that system, but it is not the only part. Patient feedback, patient outcomes, consistency in diagnoses, and other numerous factors are used to evaluate quality within healthcare systems, and EMS agencies must expand their understanding of quality improvement principles to truly impact and improve quality within the organization. With this being said, there are 6 attributes of EMS care commonly recognized as indicators of quality: safe, effective, patient-centered, timely, efficient, and equitable. As we continue to explore quality improvement in EMS, you will see these attributes again and again. Simply stated, quality within a healthcare setting is the relationship between indicators, structure and processes, and validators, outcomes. Structure is defined as the environment in which healthcare is provided or will occur. This environment includes more than just the back of the ambulance or the scene of an emergency, but it also encompasses the providers themselves, tools and resources available, in both physical and organizational settings. Process includes the interpersonal and technical aspects of treatment. The EMS provider must be able to effectively interact with the patient, bystanders, crew, and other healthcare providers in addition to being technically competent in critical thinking, diagnoses, troubleshooting, and the performance of skills. The validator against which these structures and processes are measured are the outcomes related to the change in the patient's symptoms and functioning. Essentially, structure plus process equals some type of outcome. A change in a structure or process will likely impact each other in addition to the final outcome. They are interrelated and, as a result, must be evaluated together. As just mentioned, structure is comprised of people, resources, and the environment in which the people function and the resources are used. For a quality improvement system to work efficiently, there must be structure to keep processes organized. The more complex a system is, the more structure is required to keep the system functioning efficiently. In that respect, it is important to identify who is responsible for each process and involve those individuals in the quality improvement system. This means that people must serve as the backbone to a quality improvement system. While it is not uncommon for EMS agencies to have a quality improvement department or a quality improvement officer, sustainable improvement is not possible without the buy-in of the people within the organization. Such a system must also have adequate structure and clear processes to be effective. Having the best people in the world does not help much if there is no mechanism for these people to report problems, or there is no one with ultimate responsibility for quality to whom they can report. Inversely, having great processes and structure in place for a quality improvement program does little good if the people within the organization refuse to participate within that structure or avail themselves of those processes. As far as the agency's personnel are concerned, the quality improvement team should have an organization chart that reflects the integration of the EMS quality improvement program throughout the organization. Such a chart could identify access points into the system for quality improvement activities while also identifying linkages, processes, or information channels vital to the functioning of the quality improvement program. The members of an EMS organization's quality improvement team should have a diverse knowledge base that includes expertise in administration, management, evaluation, quality improvement principles, data systems, and biostatistics, along with a strong knowledge of clinical aspects and the EMS system itself. If necessary, education and training should be provided to team members to further develop their familiarity with these various disciplines. It is also important to ensure the quality improvement team members interact with other stakeholders in your EMS system, such as hospitals, dispatch centers, local health departments, law enforcement, and so on. An effective quality improvement program is all-encompassing, and fostering these relationships is vital for maintaining and improving overall system quality. Earlier in this module, it was mentioned that the components of a quality improvement system must be intentionally designed and clearly delineated for the system to be effective. This is because any system, quality improvement systems included, are the sum of their interdependent components. Thus, to understand the system, we must first understand the components of that system, meaning all of the components must first be defined. In addition to components, the system must also have an aim. It must have a purpose or goal. Deming spoke of using science to create a system of profound knowledge that then serves as the foundation for a quality improvement system. Such a system of profound knowledge begins by changing the individual. An individual rooted safely in only existing knowledge will not see the need to improve, as all he or she knows is how things are, which seems perfectly normal to the individual. By invoking change within the individual, there is a new awareness of and appreciation for the system knowledge of variation, theory of knowledge, and psychology as a large part of managing a quality improvement system. The individual sees that there is more beyond his or her existing experiences and knowledge. This sparks ideas that lead to changes being made in the system. These changes can then lead to other changes in the system, and so on. Part of the power and complexity in quality improvement is that systems are typically dynamic and often interrelated. Part of the reason for this is because the processes within the various systems are themselves interrelated. From a quality standpoint, a process is defined as a set of interrelated work activities involving people, materials, machines, methods, energy, and environment. The combination of several processes are what define a system. A single process is routinely characterized as a set of specific inputs and value-added tasks that make up a procedure for a set of specific outputs. Essentially, things go into a process, some type of work occurs, and the end result is some type of output. Given the interdependence of processes to form systems, it is often necessary to analyze individual processes to better understand them in the hopes of improving them for the benefit of the overall system. Within this realm, quality experts routinely look at 4 factors when analyzing a process: approach, deployment, learning, and integration. The first factor, approach, refers to the organization's approach to accomplishing tasks. The effectiveness of methods and the degree to which the approach is repeatable and based on reliable data and information are fundamental to a process analysis. Deployment, the second factor, refers to the extent to which the organizational requirements are relevant and important to the organization's operations. How does the organization supply resources to the system? Is the process consistent, both in terms of the overall approach as well as the approach by individual employees? That is a key element in evaluating deployment. Learning within an organization is measured by the approach the organization takes through cycles of evaluation and improvement. Does the organization embrace change? Does it reward attempts to improve, even if such attempts ultimately fail? A system that punishes or applies negative consequences when attempts to improve wind up failing will ultimately suppress innovation, which will have a negative effect on quality in the long run. Lastly, integration evaluates how well the organization and its systems align and incorporate plans, processes, results, analysis, learning, and other activities into everything they do. Processes themselves can be broken down even further into activities, and these activities can be analyzed by measuring factors such as time, quality, accuracy, and cost. Ultimately, the key to defining quality measures is in knowing the purpose of the process steps that lead to outcomes. Defining these purposes operationally yields quality measures. To assist in evaluating activities, managers may use factors such as trending, causation, benchmarking, best practices, and published referencing. Trending is a way of looking at data graphically to determine if the outcome data indicates the activity is moving in the right direction over time. Causation necessitates the application of tests to a set of data points plotted on a process control chart. These tests determine whether or not a special cause exists within the dataset and can explain the unusual character or nature of undesirable results. Using benchmarking requires the application of known results of similar data measurements or tests as an impetus for achieving or surpassing a desired goal for improvement. Best practices uses the best known results of similar data measurements of similar tests for similar systems or operations to achieve or surpass a desired goal for improvement. If causation, benchmarking, or best practices are not available or their results need to be confirmed against additional sources, it is possible to use published results of similar data measurements or tests as a beginning or starting reference point for achieving or surpassing a desired goal for improvement. As an example, within EMS, it can be difficult to perform studies in the field due to the potential for patient harm. If a somewhat similar study was conducted in a structured healthcare setting, however, a service may utilize that publication through published referencing to drive their own improvement activities. The example provided in the book was one where a service used a Journal of Trauma study to inform their quality improvement efforts in airway management and endotracheal intubation. Ultimately, the result of structure and process are outcomes. If data shows routinely bad outcomes, an evaluation of structure, process, and activity should hopefully yield improvements to mitigate such bad outcomes. Inversely, a structure, process, and activity evaluation should be conducted if there are questions as to what is causing good outcomes because the organization wants to ensure those good outcomes continue. In understanding our people, processes, and outcomes, keep in mind that there are essentially 6 bad outcomes within healthcare and EMS that can result from problems within systems and processes: death, disability, discomfort, disease, dissatisfaction, and destitution. Death is defined as a patient who did not survive to hospital discharge or is pronounced dead at the scene of an incident. Disability is defined as the patient's level of function or lack thereof as a result of the injury or patient care rendered. The Glasgow Coma Scale is a routine measure in EMS for cognitive disability. The Cerebral Performance Category is another such measure. Discomfort looks at whether there was an improvement or lack thereof in the patient's symptoms. Pain scales are one such measure. Respiratory effort could be another one. Disease is different from disability or discomfort in that it is an outcome measure focused on the symptoms, physical findings, and diagnostic assessments or abnormalities. It looks directly at the diagnosis of the patient's illness, whether that diagnosis was correct, and the application of correct treatments given the correct diagnosis. This is a category that really evaluates the competency of the provider. Dissatisfaction looks more at subjective measures how the patient and/or the patient's family felt about the care provided by the EMS crew. How satisfied were they? Lastly, destitution is a monetary measurement for the patient and the service. Was the treatment provided at the lowest cost to the patient, the payer, and society as a whole? Was the cost of the care unreasonable? In all, these 6 factors in outcome domain, death, disability, discomfort, disease, dissatisfaction, and destitution, need to be measured based on 4 factors: performance, trending, deployment, use, and comparison. Flowcharts are excellent for illustrating processes, and other graphs or charts are great at identifying or evaluating trends in your outcomes. Best practices and published research may provide insight into the levels of performance that are achievable, and your internal data can be measured against such benchmarks for the sake of adjusting or determining performance. In returning to our initial scenario, it would be easy to initially attribute the medical error to an incompetent provider. Upon follow-up with the crew, however, they stated the error was recognized immediately after it occurred, and part of the problem was that the epinephrine was packaged in a vial that looked very similar to that of the Narcan vials. The colors were even the same. That, in addition to on-scene distractions and environmental factors in the room, such as dim lighting, were all factors that contributed to the error. In reviewing the quality domains that contributed to the error, it was determined that both structural and procedural failures occurred in this case. Within the structural domain, it was recognized that no medication should look like another. Labels, containers, and/or placement in the jump kit or ambulance should be different to assist in alleviating provider confusion while accessing medications on scene. From a procedural standpoint, having a 4th person on the crew could have possibly prevented the error by allowing the additional person to focus solely on the process of medication administration. If such staffing is not available or feasible, there could still be procedural solutions enacted to include having another provider physically confirm the medication to be drawn up, along with the dosage to be administered once the medication is ready to be delivered to the patient. While it is true that the provider failed to follow the 5 R's of medication delivery, right medication, right dose, right patient, right route, and right time or frequency, simply stopping the quality review of the error by placing the blame squarely on the provider's shoulders would not fix the underlying problem. To prevent similar future occurrences, it is vital to dig deeper to identify underlying factors that may have contributed to the error. This ties into something known as the Swiss cheese model of accident causation. Within each system, there are different processes, with each process designed to generate a specific outcome and prevent failures. As no process is perfect, however, it is recognized that a proverbial hole in that piece of Swiss cheese, that single process, can allow a risk to evolve into a loss. Because a system is made up of several processes, or pieces of Swiss cheese, it is the hope that the different holes in each process do not align. Thus, even if an error is introduced in one process, there is another process that will catch the error. Because it is not always possible to identify which precautions saved you or prevented the error, it is in your best interest to utilize all precautions available to you. If you punish the provider in this scenario and stop there, you address one piece of Swiss cheese, one process in the system, without addressing the others. Those proverbial holes of the medications being in similar containers, functioning in chaotic environments, dim lighting, and other factors are still lined up. If the only other process in that system, the piece of Swiss cheese that is the provider, makes a mistake, the system failed and an error occurs. Another best practice would be to analyze the supply chain for medication used by the EMS agency to explore the possibility of replacing the vial with a different color, size, or other type of administration device to assist providers in further differentiating the Narcan from other medications. As mentioned previously, a closed feedback loop could be established that used verbalization and acknowledgement by another crew member regarding the accuracy of the medication prior to administration. While it may not be feasible in all cases, additional procedures to be considered to minimize the potential for such errors could include requiring for providers on scene before invasive procedures or medication administrations are performed, or requiring that patients be moved to a well-lit, distraction-free environment prior to invasive procedures or medication administrations. In conclusion, the basic components of a quality improvement system include structure, processes, and measurement of outcomes. Structure is responsible for organizing people, resources, and processes. The process itself aids in understanding the reliability of trends. The outcomes are evaluated to identify potential adjustments or determine system performance. If some of these concepts are still somewhat nebulous, do not worry. We'll be working with them in upcoming modules, and they should make more sense once you see them in application.